after this outstanding lecture, I'm starting the questions, the session for the questions. And I don't have still questions till now. I'm sure the questions will come. We have great colleagues around here. So my question is about a survey that we have recently published. I mean, it was led by my colleague, Dr. Anya Keeler, about clinicians and surgeons survey regarding current and future versions of CT, MRI, LI-RADS. And I'm sure you actually participated in taking this survey, Dr. Singal. I mean, we found that 90% preferred the use of LI-RADS compared to nothing or other standardized reporting systems. But we also believe that there are some limitations to this study, which, I think it included potential sampling bias toward academic centers and potentially also towards LI-RADS advocates who work closely with participants. So if clinician was not familiar with LI-RADS, they may have chosen not to participate. Then my question to you is like, simply, how can we, as radiologists, communicate better and increase the acceptance of our non-radiologist colleagues to LI-RADS?
Yeah. So, I cited that meta-analysis that, was published, and that actually was published almost concurrently with LI-RADS being incorporated into the AASLD guidelines. And I think that, those data were critical in terms of not only the practice guidelines committee, but also the governing board accepting LI-RADS into the AASLD guidelines, because it was, once again, a very big departure from where we used to be in terms of just recommending enhancement and washout. And so I know that, LI-RADS has a working group that is specifically targeted towards generating evidence supporting the use of LI-RADS and the accuracy of LI-RADS. And I think that that is actually one of the most important things in terms of continuing to advocate for adoption. So Khaled, you mentioned this. I will say that, like, when I talk to my colleagues in academic settings, I think that you're right, that there is widespread acceptance and excitement for LI-RADS coming in. But I think that likewise, I'm sure many on the call are used to seeing this. Many of the reports we get when somebody gets CT or MRI in the community continue to get read in the old fashion, in the sense that they continue to not use LI-RADS, and there has been less diffusion into non-academic settings. So I think, I think that LI-RADS is doing everything they can in terms of communicating with, through ACR, communicating through other organizations to get the word out there. But I think in parallel, generating evidence is critical. So it's not just saying, hey, believe us, this is a good idea, but really pointing to the data that shows this is why it's a good idea, this is why this was created.
Oh, great. And to show you how much the UT Southwestern radiologists love you, the first question is from one of them, Dr. David Fitzer. Do you want to give the question?
Okay.
David?
Yeah, that was a great, and I have to say that the feelings are mutual. I think we do have a great team, and I do learn a lot from you and enjoy working with you and the rest of the HCC team. It was great to hear that we're collecting the harms data on screening ultrasound and screening AFP, which I think we don't hear a lot about, especially in the world of radiology, are the harms outcomes. In our cohort, do you think in other institutions, are we or should we be collecting those same harms data with other screening modalities, such as all the excitement with abbreviated MRI?
David, important question. So like I think that the data that, at least the data that I see that have come out in terms of abbreviated MRI early on suggest higher sensitivity, and so I think that has generated a lot of the initial excitement, because I think that's often the initial focus of, like, we need to detect HCC at an early stage, which I'm a huge advocate for. But I think that you're right. My concern is on the flip side. you know, MRI is very sensitive, which, I mean, the sensitivity and specificity is often a direct trade-off. And so my question is, and I think your point, we will have to see how often people require getting, you know, diagnostic MRIs, or, you know, they get stuck in a loop in terms of evaluating these non-specific lesions. And so, you know, how often do you continue to then find new LR3 lesions, which are clinically insignificant, that you then continue to follow indefinitely? We have to collect those data. I think it's going to be something that comes with time. And I know that there are some, particularly in the hepatology space, that continue to say, I don't see the harm of doing MRIs, you know, diagnostic MRIs or diagnostic CT scans for these false positive or indeterminate lesions. But I think the other part of this, and this is what we are measuring in our prospective cohort, is the patient anxiety that comes along with this. And so I see that in my practice, where the patient who comes in with a, you know, a positive ultrasound or positive AFP, and then it takes them a couple days to get their CT or MRI. And I've had several patients that tell me, I didn't sleep for the last 2 days until I got my MRI that showed it was not HCC. So as hepatologists, I think we do a very good job of telling patients, you're at high risk, you're at high risk, you need to have your ultrasound done. The issue being, when they have a false positive, immediately, in their mind, immediately that translates into, this is HCC until proven otherwise. So in short, I think, yes, the data are critical, and I think will be informative in terms of the best modality moving forward.
Okay, great. So Dr. Du, do you want to give the question, please? Richard Du? Okay, so I will talk on his behalf. His question is basically, what about working up LR4 lesion below 2 cm when it can change T-staging, when there is a larger LR5 elsewhere?
Yeah. So I think that, you know, so Dr. O, I think it's a good question. So first, I would say that if you have an LR5 lesion and you have an LR4 lesion, I think many of us would think that the likelihood of having HCC in that LR4 lesion is higher than if you did not have an LR5 lesion concurrently. But I would say that the only time that we would, at least in our site, the only time that we would probably do a biopsy or, you know, consider evaluation of that LR4 lesion is if it had immediate implications for management. So, i.e., you would not want to treat with an ablation, or you would not want, or that patient would no longer be eligible for transplant. But I think those, at least in our center, those situations tend to be pretty rare, that it would change your management immediately to know if something was actual HCC or not. Most of the time, what we would tend to do is to treat the LR5 lesion and then, you know, follow the LR4 lesion. But I do think that your point is well taken, that there may be some cases, and that's where, once again, going back to where we started the question and answer session, this is where multidisciplinary evaluation is critical. So, you know, reviewing that person in tumor board, talking through all of the different treatment options, if this were or were not HCC, and going from there. And, you know, I did not show those data today, but there are several studies that show presenting patients in tumor board changes staging, you know, many of the times, and actually changes treatment recommendations, and most notably improves survival for HCC. So I can't emphasize too much. I mean, I can't overemphasize the importance of presenting, particularly those kind of cases, in a tumor board.
Okay, Dr. Cherniak. Dr. Victoria Cherniak, you have a question?
Yes. Amit, thank you so much for this wonderful presentation. I have, I guess, a question that I have is that, you know, over the past couple of weeks, people would bring up an issue where, well, we'd like to use LI-RADS in our clinical practice, but there's a lot of resistance from hepatologists. And this is something that came up as questions. I know you're totally a support of it, but do you have any suggestions from the perspective of a hepatologist who's very much in support of LIRADS? How, as a radiologist, any tips that to kind of turn people on into our evil world?
Yeah. Victoria, did they say why they were reluctant to use this?
Yeah. So we didn't have this problem in Montefiore, so it's hard for me to judge. But based on other what people said, some people said, oh, they don't want to use it because there are separate ASLD criteria, although it's no longer true. Then there was somebody from Italy who mentioned that there were separate, EASL criteria. Fair enough. And somebody, some of the transplant centers, would rather focus on opt-in and not move to LI-RADS. So, and some, I assume, is just, just like you get used to what you get used to, right? So.
So the first thing, and you alluded to this, is, the old argument of like we have our own ASLD criteria is no longer true. And so, I think it was really one of the big benefits of the unification of the ASLD guidelines and LI-RADS. If somebody is using that argument, I think, referring them to the most recent version of the ASLD guidelines is something simple that would at least be a starting point. I did mention, that meta-analysis and the need for continued evidence generation, which I think, LI-RADS is doing an amazing job of doing this. And so I think pushing forward with that and just making sure that communication of the evidence base is essential. So, because I think that, when it's loudest voice in the room, it's hard to win an argument. Then it's just, once again, it's people just digging in and going at it. But I would argue that if you show any reasonable person, and I would hope that most of my colleagues are reasonable, but if you show any reasonable person the evidence base, the growing evidence base for LI-RADS, I would imagine that most of them would have a hard time continuing to dig in. If there's someone who is having, specific frustrations, I'm happy to have, one-off conversations, or, try to think through this a little bit more for specific situations. But I would say that would be my general approach, that I think that most of the hepatologists are reasonable if you say, this is why we recommended this.
I think we have Dr. Canella, Roberto Canella from Italy. Roberto, are you still here? I think you guys mentioned this last time, so you might actually state this concern.
Yes.
Roberto?
Yes, I'm here.
Buonasera, Roberto.
Buonasera. So at the beginning, it was quite difficult for our hepatology to switch from classic guidelines to the LI-RADS because of not really strong evidence, and still sometimes they remark that there is not yet guidelines, but it's guidance with lower evidence. Now I think they mostly have accepted the LI-RADS. So I'm currently working in a center that is not a transplant center. So at least in my experience, most of LI-RADS 4 are often treated when it's feasible. So this of course depends center by center.
Yeah, I think that so it's nice to hear that there's been increasing adoption even in centers that were initially resistant, and I think that once again it speaks to the evolving data that are coming out, and I think that's the easiest way to convert people. So, I mean, hopefully others continue to see that same adoption. In terms of the latter comment about the LR4 lesions, I do agree that we do see this sometimes in community practices here as well, in terms of people treating some of the LR4 lesions. I will say it can be frustrating because, obviously if that patient then presents and needs a transplant, you're not able to get the exception points because it's all, that lesion has been treated. But as long as transplant has been considered, and one can argue about the appropriate management otherwise outside of transplant eligibility then.
Okay, so
Thank you.
yes, go ahead. Who's this? Roberto?
Yeah, thank you. Just I know that the number of patients that are actually transplanted for HCC it's a small number considering all the patients that we usually treat. So our pathologists prefer sometimes to maximize the sensitivity instead of the specificity. So that was the main reason.
Got it.
So with that, I would actually conclude this session, and I would like to again thank Dr. Singal a lot for this very comprehensive lecture, which focused on the multidisciplinary and the importance of multidisciplinary approach to managing cancer and particularly hepatocellular carcinoma. So thank you very much, Dr. Singal.
Well, thank you. It was really a pleasure.